Thank you for joining us for Ahead of the Curve, our scoliosis talk on Facebook Live. Joining us today, we have a great panel of experts. We have Dr. James Policy, who's a pediatric orthopedic surgeon at Stanford Children's Health, and he specializes in scoliosis and other spine conditions. And we have Lauren Ruse, who's a nurse practitioner who works with many of our patients with scoliosis, and Dorothy Fung, who's a physical therapist who is certified in the Schroth method, which is one type of physical therapy for kids with scoliosis. And we'll hear more about that later. This team sees patients at our Pleasant Hill location, which is one of our, what we like to call one-stop shops for patients with scoliosis, where we try to combine multiple needs into one appointment. We have 6 locations across the Bay Area where we treat a wide range of spine conditions and other orthopedic and sports medicine conditions as well. And so today in our webinar, we'll learn more about different scoliosis treatment options, what life is like for kids and teens with scoliosis, and the latest research. And we welcome questions from participants, so please type them into the Facebook comments section below, and we'll address them during the Q&A portion of the presentation. Without further ado, we'll turn it over to Dr. Policy.
Thank you, Amy. So we were going to start with Lauren, Dorothy, and myself just going through a few of the main talking points on scoliosis. Thanks, Dorothy. So, what is scoliosis? How is it diagnosed? What are the screening recommendations that are currently out there? What do we do to treat it? And what are we doing in terms of research looking into scoliosis? Are the topics we're planning on covering this afternoon. So scoliosis is a curve in the spine of greater than 10 degrees when you're looking at someone from the front or from the back. So we generally grade scoliosis as mild, moderate, and severe. And here on this X-ray, you can sort of see first on the left, the curve's a bit more in the mild range. In the middle, it's more of a moderate curve. And on the right, it's more of a severe curve. We generally define mild as under 25 degrees, moderate as 25 to 40 degrees, 40 to 50 degrees is a bit of a gray zone. And severe is when the curve gets over 50 degrees. And scoliosis is actually very, very common. It's present in about 1 to 3% of the population. In fact, most people who have scoliosis don't even really know that they have scoliosis. And it's often just found when they'll get a chest X-ray for some other reason. And with scoliosis, the vast majority of people who have it never really require any treatment for it. It's something they have, but it doesn't cause them any problems through their life. Only about 1% of all the people who have scoliosis ever need to be treated for it. So, how do we diagnose scoliosis in children? It can be noted on school screening in schools that still do school screening. We do a test called the Adams-Ford bend test, which is where you have the child stand, bend forward, and then look at their back. And scoliosis is actually a 3-dimensional deformity. So we saw the X-rays earlier that show if you're looking at someone from the front, you could see the S-shaped curve, but it really rotates into that curve. And so what we see is some asymmetry of the ribs and some asymmetry in the loin, so that you can see sort of a rib rise or a loin rise, we call it. We can measure that with a device, and that's our primary screening test. Also, uneven shoulders can be a sign of scoliosis. And one of the things we have to make sure we check is the leg length difference, because some people will have one leg longer than the other. And that can actually give you a false scoliosis. It makes your spine is crooked because you're trying to compensate for the difference in your leg lengths, but you don't really have a structural curve. And the number one thing we do to diagnose scoliosis is get an X-ray. Our exam is really more of a screening tool, and the X-ray is what really tells us what's going on. And all of our treatment protocols are based on the X-ray. So we have in our Pleasant Hill office and in our Palo Alto office, an EOS scanner, which is a very low dose X-ray machine. And at a standard dose, it can take an X-ray at about 1/10 the amount of radiation of a standard X-ray for scoliosis. And for follow-up visits where we don't need quite as much accuracy or quite as crisp of an image, we can actually drop it to as low as 1/80th the amount of radiation for a standard X-ray. So we think that that really helps being able to minimize exposure, because once we have someone who we're following for scoliosis, we could end up getting 8, 9 X-rays over time.
So currently, the screening recommendations by the American Academy of Pediatrics, the Scoliosis Research Society, and the Pediatric Orthopedic Society recommend screening to be performed twice for females between the age of 10 and 12 years old, and once for males between the ages of 13 to 14 years old. Early detection really matters because there are things that we can do to prevent a curve from progressing or worsening. Treatments are usually only initiated when a curve reaches about 25 degrees or into that moderate category, as Dr. Policy was discussing. And current treatment modalities include bracing and physical therapy for that moderate range. Once you get into the severe range of around 50 degrees or greater, that's when we start to discuss surgery. Bracing is our best method of treating scoliosis. Again, that is only recommended when you reach that 25-degree measurement on an X-ray, and that is when we would recommend starting a brace. Bracing is very effective. It's almost 80% effective when worn accurately or appropriately. Bracing is very dose dependent, meaning that the more you wear it, the more it works or the better it works. We currently have a way of monitoring how much the brace is actually worn by using a small temperature probe that can be put into your brace. Here is an example of one, which is actually an older model. Currently, they're a lot smaller in size. And it monitors the temperature of your body against the brace, which can then let us know exactly how many hours per day you're wearing the brace. Oh, sorry, can you go back to the brace? Sorry. There are different types of braces. So there are several different types. One is the Boston brace. One is the 3D printed Rigo Chanot brace. And another is a WCR brace. So depending on what type of curve you have, it may be recommended for you to get a certain type of brace versus another. Now we can move forward. How does scoliosis impact your ability to play sports and be active? Basically, it doesn't really affect your ability to play sports and be active. We encourage you to participate in any sports that you would want to otherwise participate in despite having scoliosis. And there is no evidence that supports that a curve that in a athlete leads to progression when you're playing a certain sport. So it doesn't matter what sport you play. It doesn't matter how often you play the sport. There's been no link to certain amount of activity or lack thereof with progression of a curve.
So I'm going to talk about Schroth physical therapy, which is a specialized physical therapy where we do exercises that are specifically for scoliosis. We use these exercises to build strength and flexibility so that we can help change and attain a better posture and alignment for you. We also use specific breathing exercises to work on some of that rotation in your trunk that Dr. Policy was talking about earlier. This is really best done when you're doing bracing together as like a team. Those who benefit the most from Schroth physical therapy are usually curvatures that are in the 20-25 degree range and above. And usually you hopefully will have some growing left. However, if you still do not have any more growing left, then that's fine. You can still benefit from these physical therapy exercises. Also, the ability to practice these exercises and have the time to do so, because it does take some amount of time every day, is key. For Schroff physical therapy, the research shows that we can change the strength and ability to expand your chest to change those rotations. And also doing the exercises while wearing a brace is better than just bracing. And logically, you get better results if you're compliant with the program. Now back to Dr. Policy to talk about surgery.
Thank you, Dorothy. So surgery is only needed in a very small percentage of patients who have scoliosis. We generally hold off on surgery until curves get to more of the severe range. There are a lot of different surgical options. It depends on your age and the degree of the curve. The most commonly done surgery for idiopathic scoliosis is a spinal fusion, which is usually done through the back, where we use metal rods to help straighten the spine and hold it in a better position. And then we fuse it so that it can become one solid piece of bone through that area. There are some other options for younger kids, especially very young kids. We often use growing rods, which can grow with them. So they're inserted in a similar fashion to doing the fusion, but we don't actually fuse the spine. And then they have a magnetic motor that we have you come into the office, and we can lengthen it a few millimeters every 3 or 4 months until you're old enough to, at that point, generally have a fusion. There's also a newer technique called vertebral body tethering, which is sort of for an in-between age group of patients where they have a curve that's at the low end of severe, and they still have a couple, 2-3 years of growth remaining, of solid growth remaining. And we can put a tether across the front of the spine so that it holds it in place and allows the spine to grow straighter as kids grow. That's again, a relatively new treatment, and there's not a lot of long-term data on it. We do know for kids who have the posterior fusion, there are 40 and 50-year follow-up studies showing that people do very, very well long-term following the fusion. We also know that with long-term studies of people who have mild or moderate scoliosis, that long-term they also do very, very well. In fact, there was recently a study that was looking at up to 60 years follow-up of people treated non-operatively for scoliosis. And as long as their curves are in the mild and moderate range, they do very, very well, well into their adult life. And currently at Stanford Children's, we have several randomized clinical trials that are underway. And these include looking into postoperative pain management for our patients who undergo fusion, looking at ways that we can encourage brace wear and improve compliance with brace wear, and looking at factors that impact compliance with brace wear. We're also looking at ways of imaging the spine without x-rays using the 3D camera, and potentially making that a useful tool for pediatricians doing screening, so they'd have a more sensitive screening test. So I think at this point we can open things up for questions, and I see a few in the chat. First is, how has treatment changed over the years? That's a great question, and treatment has changed dramatically over the years. The treatment of scoliosis goes all the way back to Hippocrates. He was the person who coined the term scoliosis, and he he created a thing called the Hippocrates ladder, which is essentially a stretching board that he would put people on, and then he would have side struts that would compress the points of their curve to help straighten it out and hold them in place. Over the years, bracing was developed, and it was about the 1950s that we started getting into our more modern style of bracing. And since then, there have been many, many advances in the type of brace. Currently, the focus is really looking at more of the three-dimensional nature of scoliosis, and that's where some of our more modern braces and the Schroth physical therapy come into play. Another question is, if surgery is needed, how long is recovery typically? That's another great question. I think most of our children are in the hospital for about 4 days after a surgery, and they're on some pain medicine for a few weeks after the surgery. Generally, by the time you're a week or so out from the surgery, the only medication you would need is Tylenol and or Advil, and usually patients are on that for a total of about 3 to 4 weeks. We do use narcotic pain medication for the first week or 10 days after the surgery. We try to get kids off that as quickly as possible. And then at 3 months, we let you get back to doing lighter physical activities like jogging, riding a bike. And at 6 months, we would let you get back to full physical activities like playing soccer or baseball or basketball, and pretty much getting back to your normal life.
Some other questions that have come through the chat are, is scoliosis painful? In general, no, scoliosis is not painful, especially for a mild and a moderate curve. Sometimes if a curve gets into the severe range and you have quite a bit of rotation, some patients can have some back pain, but again, that's not until you reach a very severe level of scoliosis. Another question that's come through the chat is, do heavy backpacks cause scoliosis? Really common question. There is nothing that you can do that will make a curve better or make a curve worse. So carrying a heavy backpack, sleeping on a certain mattress, again, doing a sport or not doing a sport will not have an impact on a curve. Another question is, what does an orthotist do? That's a really good question. An orthotist is a tactical person that is actually responsible for making the brace. Each brace is custom made to your body or each person's body. So you cannot use someone else's brace. It has to be custom made to you. And the orthotist is responsible for making that. We work really closely with orthotists throughout the Bay Area to get the right fit for a brace. And we're constantly in communication with orthotists and seeing patients back in between their visits with the orthotist to check an x-ray and take a look at how the brace is actually correcting a curve. So if you do have scoliosis and you're being treated for it, you'll work closely with our team and with an orthotist as well.
And I think someone asked the question, what are new developments? What new developments are changing scoliosis treatment now and in the future? I think in the United States, the addition of Schroth physical therapy is a relatively new development. It's been standard of care in Europe for quite some time now, but it's just been over the last few years that it's become more common. And more academic institutions like Stanford are embracing it. And I also, there are some new styles of brace that are continually coming out. The surgical techniques are continually changing, and new surgical techniques are always on the horizon. One of the biggest developments in terms of safety during surgery that's come up in recent years has been 3D navigation, where we are able to use a navigation tool like you would have in your car, telling you how to get to a specific address. On a more micro level in the operating room, we can use those tools to help us more safely apply the implants we use in surgery to the spine, so that we can protect the nerves and the spinal cord itself. Dorothy, did you want to talk at all about some of the progress in Schroth therapy?
So there are a lot of different methods going on, mostly all based on Schroth physical therapy, but there is a lot of new evidence and research being done on Schroth physical therapy. So it's ever changing, and they're getting updated so that we can get better results with the physical therapy exercises.
Great. Well, I think we've covered all of our questions. So thanks again, everyone, for joining us today. And if you have any questions about our scoliosis services or you'd like to schedule an appointment, please call us at the phone number below, 844-41-ORTHO, or visit our website to learn more. And thank you again.